To start, I mean, it's almost a full house. That's good news. I don't know where is Julia. Julia was responsible for recruiting the people. I don't know where she is. She's there. Okay, good. Well done, well done. So you have to speak in the microphone. That's what the technician told me. I guess it is, but really in the microphone. So we will start. I mean, good afternoon. I think this is a good session, quite exciting. I mean, it has been rehearsed a few times, and it is sponsored by SMT, and the title is precisely Supraflex for high-risk patient and lesion, from practice to evidence-based medicine, proved through fire and compare. And I think that you will see some slide on the future, you know, the peep show about the next big trial. So we have Professor Onuma, which is going to advance the first slide. Personally, I have this conflict of interest. And then what are the key questions for this afternoon? First, to understand the coverage of thin-strut sirolimus deaths in small and large vessel, in diabetes, and in STEMI with OCT analysis. Quite demanding. Next slide. Yeah. To understand the performance of the Supraflex stent for high-risk patients, such as high bleeding risk, or the elderly, which is more and more common in our practice. And the last objective of the day is to preview, that will be quite exciting, the anticipated outcomes of a major randomized trial in patients with triple disease. Yoshi, you can introduce our discussion.
Yes. So in the panel, we have a privileged discussant, Raul Moreno from Spain, Professor Helge Moorman from Germany, Beren Sit from the Spain, Ashok Des from the India, and Joanna Wikrzykowska from Groningen in Netherlands, and Jacek Legutko from Poland. Also in the front row in this speaker room, we have speakers Tsunin Tsai from the Ireland, Atul Abiyanka from India, Gianluca Campo from Italy, David Reisner from Germany, and Anuruk German Kulkit from Thailand. So for the audience, if you have any question, please feel free to ask your questions in the app. We will try our best to answer all your questions.
Very good. So we will go for the first talk. The first talk, maybe you remember, 2 years ago at PCR, we had a case with Bruno Farah from Toulouse. That was a main stem with involvement of the LED and the circ. And the case was entirely prepared by multi-slice CT scan. And Bruno Farah was guided in his therapy by that technique. Now, we are 2 years later. I'm very curious to see, like you, what are the results of these Supraflex in the main stem. John, the floor is yours.
Yes, thank you so much for the introduction. I am also very curious about that case after 2 years. And so that case was an 81-year-old gentleman who had the new angina, CCS class 3. He has no past medical history, and the kidney function was okay. He has preserved ejection fraction and moderate AS. And then after the heart team discussion and the CT was reviewed by the heart team, we decided to go for a CCTA-guided PCI. This is the CT that was 2 years ago. We see some non-obstructive calcified lesion in the right and severe calcified lesion in the left main and in the LAD middle. So this is the CT analysis that was 2 years ago. You see that almost 360 degrees of calcium in the LAD distal that extend to the LAD proximal and the circumflex. The FFR CT was very, very ischemic, and then the diameter stenosis was 71.4%. So we planned a PCI with the CT information. We selected the guiding catheter with the size of the sinus of Valsalva. We decided to use a shockwave balloon to open the calcium because it is almost circular. And then we selected the working angles. The first one is for the guiding engagement. The second one is for the left main bifurcation procedure. And then we measure the stent that is going to be required. Based on the FFRCT PCI planner tool, we decided only to do the left main bifurcation because after the left main bifurcation is treated, the distal LOAD is okay. Only the second diagonal is still ischemic. So this is the procedure 2 years ago. Then we engage with the 7 French guiding catheter, and we dilate it with a shockwave balloon over 12 cycles, 10 seconds each, and the dilatation result was pretty good with some dissection. After the port, we do an angiography, and we see that the circumflex was a little bit pinched, so we rewire and perform another stenting in the circumflex with the Supraflex Cruz 2.5 over 12 millimeters, and then we perform a kissing balloon technique, and then a final pot. After the final part, we perform the OCT to see if we have created any dissection, any malposition, and whether the stent struts are well in their place. So this is the OCT finding. To the right, you will find the LCX ostium, and you will find that there's basically very little stent strut protruding into the left main, which is great. And then the stent is covered in the circumflex as well. So the result is quite optimal. The position was great. So the patient was discharged. And 2 years later, he's now 83 years old, and then he was active, non-symptomatic, doing well. He was asked to return to the clinic just to get a CT scan follow-up for this session. And this is the CT scan follow-up. You find the similar looking RCA. There's a motion artifact in the RCA, but the left main you see some calcium, but also you see the stent in the maximal intensity projection. And you see a little bit halo outside the left main. That's the thin-strut supraflex. And then the left main distal, you see the calcium over here that is creating some blooming artifact. And the stent is well open in the LAD proximal, LAD middle, and in the circumflex as well. You see a tiny halo outside the stent that does not impede your ability to visualize the patency of the stent in the follow-up CT. So the diameter stenosis at the follow-up was 13%, which is great. And then on the MIP, you can clearly see inside the stent. There's a little bit hypoattenuation looking thing, but that is just the blooming artifact created by the calcium. So that's the follow-up. You can see the very fast fly-through. You can see some whitish calcium or stent outside the vessel, and you can see it's both pattern and very well expanded. And the functional residual syntax score was 6. So the take-home message for this case is that CCTA can guide high-risk procedure, and that the PCI can be guided with high precision and optimized with OCT. And follow-up with the CCTA is quite visible, as this study that was 20 years ago, that showed it was possible 20 years ago now, and is probably going to be the daily practice for the future. Thank you.
I think quite exciting case.
Yes, congratulations. This is an impressive case of illustrating the usefulness of CT scan. The question is related with the safety, more concisely with the radiation. Given that patients are going to receive also radiation in the cath lab, how is the future of reducing radiation associated with the CT scan in these patients? Related with this, elderly patients could be more easily candidates for doing CT scan before, because of the problem of radiation is maybe not so important?
Yeah, so I think radiation is a big concern then when you are looking at this kind of imaging. But CCTA is now improving greater and greater, and now you have like GE and Siemens have like sub-millisievert protocol that you can achieve a radiation with the dose of the KUB. That's one thing, and the other is that CCTA can help provide you information about the anatomy, which can assist your invasive coronary angiography. In the discharge trial, we found that the extended MACE, which included 48-hour procedure-related complication, that was reduced significantly by 40% when the diagnosis was guided with CCTA. So this is why I think partially the reason why now the US and the ESC guideline put the CCTA as a class 1 indication.
Thank you.
Very good.
Yeah, very good. Thank you, John, for your answer. So we will move on to the next talk. So the timing and extent of the healing after the stent implantation is influenced significantly by the design of the stent. The Supraflex Cruz stent incorporates a unique design, especially intended to have a good delivery of the system, also the expansion of the stent, but also intended to have a rapid and good early healing after stent implantation. So the Dr. Atul Avianka will now present comparing data demonstrating tissue coverage after implantation of Supraflex in challenging subcohort of the patients and the lesions, including the small vessel, STEMI, and diabetes. So floor is yours. Please proceed.
Thank you for this privilege. So what I'm presenting to you today is the OCT data in a temporal spectrum starting from 1 month, then 3-month data of OCT, specifically in high-risk subsets of diabetic patients and STEMI, and then comparison of large versus small vessel healing with 3-month OCT, because this is the only stent which is available in larger diameter in the same thickness or thinness. And then comparison with the Zions family of stent at 6 months with the Taxco study. All these studies used the standard methodology, all standard parameters were analyzed, and this was done at independently by the Stanford Core Laboratory. So looking at the CBOCT study, which is a single center investigator-initiated study of 29 patients, of which 25 were analyzed, others not because of technical inadequacy. So this is the RCS stent, 35/28. At 39 days, you can see that there is a 81.8% covered struts. The NIH thickness is about 75. So fairly good healing in this. This is a case of RCA with overlapping stents, 324 and 332. And you can see here in that enlarged picture that there is a complete healing even in the overlapped area of the stent. So in spite of that overlapping, the intimal coverage is quite complete. This is another stent, 2.75 millimeter diameter in LED. At 29 days, you find an excellent coverage of 97.3% of struts, and the NIH thickness is about 117 microns. And this is what you will see consistently in subsequent studies. So if you compare the 1 month follow-up, then you can find that as compared to many other comparator stents like Zions, Biofreedom, Synergy, Resolute, polymer-free stents, the strut coverage was the highest, that is about 91.26%. And the only closest that came was the polymer-free stent with 89%. All the rest were in the range of 73 to 82%. So this is giving much better coverage with the thin strut. Now we look at the 3-month OCT analysis in specifically diabetic patients. So this is 40 consecutive patients who consented for the OCT, prospectively consented. All patients were evaluated at 3 months. And this is an example of extremely well-covered stent. 99.8% of the struts are covered and with a fairly thin neointima. So if you compare the various studies in diabetic patients or subsets of those studies in diabetic patients, then you will find that the OCT study found 99.9% of the struts were covered. Now, if you look at the other studies, actually none of them are there at 3 months. So the other studies range from 6 to 12 months. So in spite of the fact that this is only at 3 months, the coverage was better. Although this is again not a randomized comparison, but just historical comparison. If you look at the mean NIH thickness, it is quite similar to most of the other stents. Looking at the 3-month OCT in STEMI patients, again a specific high-risk subset, 23 patients evaluated at 3 months. So there is a uniform suppression of neointimal hyperplasia. There is a minimal neointimal thickness, but the stent struts are very nicely covered with thin tissue. And even the lipid-rich plaque in the middle frame, you can see, is adequately shielded by a nice thin neointima. So if you look at the strut level analysis, then 99.94% struts were covered in STEMI at 3 months. The mean NIH thickness, as in previous studies, is in the range of 110 microns. The concern about the thin strut has always been that what about large diameter? Because as I said, that some brands are available in different thicknesses for different diameters. This is the only stent which in all diameters comes in the same strut thickness. So we compared from the previous studies the small versus the large diameter. You can see that the diameters are significantly different in the two groups. What is important is that the mean stent eccentricity index was pretty low in both the groups. That means the uniform expansion that we are concerned about in thin strut stents was clearly visible irrespective of whether it was a large vessel. The NIH obstruction was very similar, whether it in small or large vessels. The NIH volume obviously was relatively slightly larger because of the large size of the vessel. If you look at the percentage covered struts per lesion, then it was 99.9 in both the groups. So very nice coverage, whether it was a small vessel, whether it was a large vessel. Also, if you look at the NIH thickness or mean neointimal unevenness score, the thickness was low and it was even. So that means even in large vessel, the healing was uniform, circumferentially even. Then we have this comparison, which is at 6 months, compared to Giant's family of stents. This is the case of Tetraflex, which is same as the Supraflex Cruz. Stented length of 39, 98.93% struts were covered. You can see pictorially excellent healing, very nicely covered stents. This is Giant's, which is covered 99.81%. And then if you look at the data, then it is pretty similar in Giant's and in the Supraflex Cruz, that it is 98.13 and 97.58. The mean NIH thickness was quite similar. The unevenness score also was similar. So compared to the Giants, which considered as a benchmark, we also have the clinical trials against this, but this is the OCT comparison showing that the healing was very similar, and this is at the end of 6 months. So if you look at the time spectrum, then whether it was at 1 month, 3 month and above, the coverage was excellent. At 1 month itself, it was 91.26. And then after that, it was almost like practically totally covered, going above 99%. So in summary, whether in high-risk subgroups like diabetes, STEMI, whether in small vessel diameter or large vessel diameter, Supraflex Cruz OCT analysis showed excellent coverage with a very thin neointima and a uniform neointimal growth with even stent expansion. So stent expansion as measured by eccentricity index was circular and uniform, and the low NIH unevenness score indicated circumferentially uniform NIH in small or large vessels. Thank you.
So that was very interesting. I mean, why we don't go to a lady and think Anna has a question for you.
Thank you. Thank
And
you
if
so
we
much.
have more time, maybe Raul will have a time.
Okay,
But let's see
okay.
first Anna.
Okay, congratulations on your presentation. Excellent. The use of drug-eluting stents in small vessels is growing, and may the results of strut coverage with Supraflex stent, in this case in small vessels, be a reason to use drug-eluting stents instead of drug-eluting balloon in this subset? What do you think about that?
Yeah, I think the data, we don't have the data of very small vessels, that is 2.25 millimeter vessels, so I can't comment on that. But the rest of the vessels, if you consider 2.5 onwards, then definitely the thickness of NIH is so low that probably the DES, I think, is superior in terms of, because it also gives a structural support apart, unlike the DEB.
Very good. I think we are on time. So, Raul, you can have one shot.
Yeah, it is related. In the last study, when comparing the science and the Supraflex, the endothelialization was similar, but the follow-up was at 6 months. So maybe that the ideal time of follow-up may be 30 days when comparing different stents, because at 6 months, maybe if any stent has a delayed endothelialization, you don't get the differences.
Yeah, I think looking at this data, probably the further comparison should ideally be at 30 days with any stent, because finally that would be more important than looking at 6 months, because practically all stents seem to be covered at 6 months. So although our study was at 6 months, but I showed the historical data where you have the data with Giants where it was almost 10% lower as compared to the Supraflex Cruz at 1 month.
Thank you. Thank you.
Very good. No question from the audience. Don't be shy. No? 1 time, 2 times, 3 times, adjudicate. Okay. So we go to the next, and the next will be Gianluca Campo. I think what you're going to hear is something quite exceptional, because you will hear about the pooling of almost 1,000 patients who receive 1 month of DAPTs. So he has pooled with his team the data of FIRE, which was published in the New England, the data of COMPARE 60-80 from Peter Smith, and finally the Cruz HBR. So we will be a little bit more educated after that talk.
Thank you. Thank you for the introduction and for the opportunity to be here and to discuss with you about the performance of Supraflex Cruz in HBR patient. Please, first, give me a few seconds to introduce why it is so important to talk about HBR patient. HBR patients are at very high risk of ischemic events. This is quite strange based on the name, but as you can see in the slide, the higher risk of HBR patient in terms of mortality and recurrence of MI is incredible. And the key point is that we cannot rely on DAPT therapy to reduce this risk. So we need something else. We need tools, different strategy to minimize the risk. Just a case to introduce the topic. 83 years old, a lot of cardiovascular risk factor, and in particular, please pay attention to atrial fibrillation in oral anticoagulation and moderate kidney dysfunction. The patient was admitted to hospital for inferior MI, and as you can see in the screen, there was a culprit lesion in the posterolateral branch, and a lot of disease in the left coronary system, so intermediate disease in the mid-circ, a very long serial lesion on the LAD. The question for the management of this patient are many, so regarding the treatment of the culprit lesion, complete revascularization, which guidance, which timing, what we did. We followed what we did in the FIRE trial. So we started fixing the culprit lesion with a Supraflex Cruz 2.5 with a very good result. And after 2 days, in a staged procedure, we proceeded with the functional evaluation. Why this? Trying to minimize the lesion at the vessel needing stent implantation to maximize the benefit of PCI. So, as you can see, we have a focal, no flow limiting lesion in the circ, so we did not proceed with PCI. On the contrary, there was a very significant lesion on the LAD, in particular a serial lesion needing PCI. And we proceeded with the implantation in overlap of 3 Supraflex screws with post-dilation and with a very good final result, as you can see in the angio. So, which is the key point behind these cases? We have a patient a very high bleeding risk, so at high ischemic risk, because the patient is in oral anticoagulation, chronic kidney disease, age, so more than 75 years old, and the patient received 4 Supraflex screws during the index and the staged procedure. In agreement with current guideline, the suggestion is to perform triple antithrombotic therapy just for 1 week, and after this maintain the patient in clopidogrel and oral anticoagulation. So the question is if we have some data supporting this approach with Supraflex screws. And the answer is yes, because we have a lot of trial with HBR patient showing the performance of the stent in this specific case. So we have the data from the Cruz HBR, the 5 trial, and the Compare 60/80. In particular, what we did, we collected all the information, the individual data, from the 3 main studies, including more than 1,600 patients with HBR characteristic in agreement with the current classification, and receiving Supraflex Cruz implantation in 1 or more lesions. Patients, you will see in the next slide, were divided in agreement with the length of the dual antiplatelet therapy. Please note that this is not a randomization because the focus of the trial was different. So in this case, the decision was the decision of the operator, if to maintain or not the APT for 30 days or less or a longer time. The goal was to compare the performance of Supraflex Cruz with other study with other stents, and in particular is to compare inside this population the performance in terms of efficacy and safety of the 2 different antithrombotic regimens. So what we find? First, the characteristic of the population. Please note the mean age, 80 years old. So the population was very, very older, with a lot of comorbidity, chronic kidney disease, a lot of cardiovascular risk factor. All the vessels were treated, so stent in the left main, LAD, RCA, a lot of patients with acute coronary syndrome, so 60%, and as you can see, the large majority of these patients were in oral anticoagulation, and the clopidogrel was the most used antiplatelet agent. Now, please note the blue line, the very short DAPT regimen in patients where the operator decided to use a short regimen. These are more than 700 patients, near 900 patients, receiving a very short DAPT regimen, so 30 days or less. So patient only in clopidogrel and oral anticoagulation, mainly, or only in aspirin if we decided to stop clopidogrel. As compared to different study and different stent platform, we did not find any difference in terms of efficacy. So, as you can see in the slide, Supraflex Cruz was non-inferior in terms of device-oriented cardiac events, so cardiac death, recurrent MI, and ischemia-driven revascularization. Please note that this was independent to the DAPT regimen length. The second most important point is reported in this slide. As you can see, here we have all the patients with HBR characteristic, all the patients treated with Supraflex Cruz, divided in patients with a very standard DAPT regimen, so more than 3 months, 6 months. And on the other side, the red line, patient receiving 30 days or less of DAPT. As you can see, any difference was observed. So again, the incredible efficacy of the stent with any concern regarding ischemic complication. And please note this very important data regarding stent thrombosis. We are talking about very complex patient, older patient, a lot multi-vessel disease, severe calcification, bifurcation, and as you can see in the FIGHT trial, the rate of stent thrombosis was less than 1%. In the meta-analysis, despite a very short DAPT regimen, the rate of stent thrombosis was around 1%. And in particular, no difference based on DAPT regimen. So if you remember the first slide, we are in the same line. So the key point to reduce ischemic event in HBR patient is not the DAPT regimen, but is the platform, the stent, and the technique of implantation. Finally, this is expected, when we reduce the length of the DAPT regimen, we reduce the risk of bleeding complication. And we know that it is very important in HBR patient because HBR patient after a bleeding show an incredible increase in death. So in conclusion, dear colleagues, we have many studies showing the efficacy and the safety of this platform in HBR patient. I believe that our meta-analysis strongly confirmed that this is a good platform for all patients, but in particular for HBR patients for complex conditions where we cannot rely on DAPT to reduce ischemic events. Thank you for your attention.
Thank you very much, Gianluca. I think it's important communication on a larger group of patients. We have potentially 4 questions, but let's start by the lady, Joanna.
Sure. So you show the different options for the regimens, and I think the magic time is really those 30 days when you see beautiful coverage of the SMT stent, and you can actually start to peel things away. There's one regimen that is being explored now in one of the running studies, and that's keeping actually ticagrelor monotherapy for just 1 month and then doing NOAC only monotherapy. So very, very short, actually monotherapy.
Monotherapy.
What do you think about that? Do you think that we're justified to do it? Is it safe?
Yeah, so this meta-analysis is strongly supported this potential. It's a totally different approach because in this meta-analysis we have dual antiplatelet therapy for a short time period, but the data, in particular the data regarding stent thrombosis, because this data is reported in all the trial with Supraflex Cruz, so I believe that we can try to move from a DAPT regimen to monotherapy, and obviously the Matrix 2 trial is ongoing, we are enrolling patients, and we will see the result.
Very good. I think we have time for a second question by a second lady.
Yeah. Thank you, and excellent presentation, Gianluca. A quick question. Did you analyze the differences between acute and chronic coronary syndrome?
Yeah. Thank you for the question. This is very important. As you can see, 60% of the patients were admitted for MI. So we performed the interaction analysis between stable and acute patient without any difference. So the results were consistent across the 2 clinical presentations.
Perfect.
Very good. Jacek, what about a short question
One
there?
short practical question. What is important to lower the risk of stent thrombosis is a good platform that we actually know that it is. But what is your protocol for stent optimization? How often do you use intravascular imaging? Is it what's your strategy?
Yeah, totally. So in general, to reduce the stent thrombosis, the most important thing is the sizing of the stent. So the use of intracoronary imaging is really important. And the other key point, in particular, when you talk about older patients, severe calcification, is post-dilatation. So this is a general practice in our cath lab. I think in the large majority of the cath lab, adequate choice of the stent, avoid undersizing of the stent, and post-dilatation with non-compliant balloon.
Raul, maybe just in the last 30 seconds.
Okay, yes. It's related with AF patients with atrial fibrillation. Are all the patients with atrial fibrillation the same? That is, how can we calculate or estimate the bleeding risk? So in order to identify those patients in whom very, very short triple antiplatelet therapy, maybe less than 1 week, could be prescribed.
Yeah, this is a very important question because we have a lot of score evaluating both ischemic and bleeding risk in patients with atrial fibrillation. I think that the main important message is in patient in oral anticoagulation, the key point is to avoid bleeding complication and try to avoid to use antiplatelet therapy for the reduction of ischemic event. Now we have other tool to reduce ischemic events, so I believe we can rely on stent, in technique, to avoid ischemic, avoid to use excessively the antiplatelet agents because the risk of bleeding complication is very high.
Very good.
Thank you.
Okay, it's clear that in our practice, the age, what I call the age pyramid is changing all the time. I mean, 70, 80, even 90 now. So David is going to address that topic of the octogenarian and even above.
Thank you very much. Can I get my slides? Oh, sorry, no. Okay. Perfect. So, dear Chairman, dear panel, ladies and gentlemen, I'm very happy to present you some ideas or some basics and some backgrounds that leads to the Cruz Senior registry. And I think this will close the gap in evidence that we already discussed. So, you know, every one of you in the next years all over the world, and especially in Europe, we will have a lot to do since the prevalence of coronary artery disease will increase. More than 30% are expected, for example, for Germany. This is in parallel with a demographic change, and you see this, and in 20-25 years, there will be a lot of patients in the cath labs being 80 and more old, and this is a self-fulfilling prophecy since age and coronary artery disease are developing dependent from each other, and maybe age is an independent or dependent cardiovascular risk factor. So this will lead to increasing number of PCI procedures. PCI in these older patients is quite challenging, and we already saw some examples. You have to think about the lesion complexity, which is normally much higher than in younger patients. You have high ischemic risk, mainly driven by age and frailty. You have a high bleeding risk with similar reasons, and you have a lot of comorbidities that makes it very difficult to decide how these patients should be treated. With respect to the last large stent trial we saw, and here I chose the BioFlow 5 as well as the TALENT study, you see there were patients in that not represent this group of older patients, mean age of 64, or here in the BioFlow 5 study, or of about 66 in the TALENT study. So this means we have no study evidence for such high-risk patients. This is important, and again, this is a subgroup analysis from the BioFlow 5 study, and as you can see, with the endpoint of target lesion failure at 12 months, you see different aspects between patients aged older than 75 and patients below this threshold. So age matters, but we don't know how. Second, and I think this is one of the main questions we have to discuss, is what is the treatment target for patient in octogenarians? Is it a symptomatic reason? Is it a prognostic reason? Or do we only want to optimize the quality of life? And I'm very happy that this topic is actually discussed when we design new coronary revascularization trials, the paradigm shift of living longer and living better. And there has to be the individual patient life objectives as a mean endpoint of this study. And out of these reasons, we designed the Cruz Senior study 3 years ago is a post-market registry to evaluate the safety and efficacy of the Supraflex Cruz stent in the treatment and the all-comer treatment of octo and nonagenarian all-comer patients. This is a prospective, multi-center, open-label, single-armed, non-interventional, observational clinical investigation, and it was designed to enroll 2,000 octo and nonagenarians, all-comer patients in a lot of sites in Germany, Switzerland, and Austria. All these patients underwent PCI using at least one Supraflex Cruz sirolimus eluting stent, as we do it in the current practice, and the patients were followed up over 12 months. So at the end, we have an all-comer patient cohort older than 80 years with non-ST elevation, acute coronary syndrome, stable angina, or silent angina treated according to the ESC guidelines. And what do we want to, or what were the aims of the Cruz Senior registry? We want to close this evidence gap by seeing by evaluating the results of the Supraflex Cruz stent in such an aged, real-life patient cohort representing a significant, most complex high-risk patient cohort in the daily routine. Secondly, and this is important, from my side, we want to prospectively evaluate the clinical and the patient-centered reported outcome represented by PROMS of the PCI procedure for itself. And third, and this is quite innovative, we want to evaluate new markers representing the individual functional and frailty patient status to evaluate new concept for risk stratification in such an aged patient cohort. How we did this, and this is really the first study doing this, in this we included a comprehensive frailty assessment representing different aspects of the patients, including the mobility, the cognition, frailty, nutrition, and the biologic age. And this is a very, very interesting point of care testing of the biological age and frailty of the patients by measuring, it's only about 10 seconds, non-invasive transdermal, the concentration of advanced glycosation and products. This is a H protein by skin autofluorescence. So at the end, the study was successful yet. We included 1,939 octo and nonagenarians patients. The inclusion of the patient ended at the first quarter of the last year. And now we assess the 12 months follow-up, assessing the clinical outcome with the endpoint device-orientated, as well as clinical MACE endpoint, as well as bleeding rate and device failure rate, as well as a symptomatic endpoint represented by the Seattle Angina Questionnaire at 6 months, and the patient-orientated quality of life by measuring PROMS. So I am very pleased to present you the first results, starting with the baseline characteristics. You saw what we want. We get patients with a mean age of 48 years. These were 38% female patients, which is quite impressive, but that's typical in this aged patient group. About 1/3 underwent PCI for acute coronary syndrome. About 1/3 were diabetic patients. And this is important, and we already discussed this in the last presentation, you see these were really high risk, especially bleeding high risk patients. You see the different factors that are established for being major risk factors for bleeding, and each of these patients had nearly 2 of these different factors, and in additional, in some cases, another minor bleeding risk factors as, for example, moderate CKD. Why this was done, and the other reasons out of the acute coronary syndrome, were mainly stable angina, and this was really surprising, and you have to see this very crucial in our registry. 22% of the patients were treated over the femoral access in this high-risk patient cohort, and you see these were really complex lesions with a mean lesion length of about 30 millimeters, about 20% bifurcations, about 20% multivessel disease. And if this was bifurcations, these were mainly true bifurcations with main and side as treatment. These were calcificated in about 60% of the cases, and the lesions were adequately prepared. So, and this is a bit continuation what we discussed in the last presentation. 70% left the hospital with DAPT and about 38% with the oral anticoagulation medication. And this was quite surprising for me. Despite this is possible according to the ESC guidelines, you see mainly of the patients was discharged with the recommendation to treat antiplatelet therapy for 6 months or longer. So, and this is very impressive. These are the first results from the procedural outcome using this Supraflex stent. And you see in 94% in this really high complex patients and lesions, there was a device success. There was in 99% procedural success, and there was a lesion success defined as residual stenosis lower than 50% of the target lesion in 99.7%. Given the limitations of a registry, there was only a very, very low rate of device malfunction that was reported, with only one embolized or lost stent in this registry, and there were other reasons, one case of a stent, of a broken stent. So really amazing results for this high-risk cohort and high-risk lesions. So at the end, I want to conclude. The PCI in an aged octogenarian population remains, from my side, the challenge for the future in interventional cardiology. We have not dedicated studies, and these should target PROM endpoints and are urgently necessary to make sure that we have evidence-based strategies for the future. Cruz Senior provides for the first time dedicated evidence that the Supraflex stent system helps to treat these most complex high-risk patient cohort with high complex coronary lesions with impressive procedural results. And this is quite amazing, the impact of frailty on PCI outcome and all these questions can be answered and will be presented at the TCT this year. Thanks for your attention.
Thank you, David. I think we have time only for one question. Joanna, you want to try that?
Sure, really compactly. I mean, I think in the other elderly patients trial, the FIRE, we saw that there's benefit of complete revascularization. How do you think this will look in your trial? Will you be able to also see there are patients that are frail that perhaps we should hold off and those no longer benefits from complete revasc?
It depends on what endpoint you want to go for. If you go for a clinical endpoint, for a MACE endpoint, I'm pretty sure that also complete revascularization is superior. But the question is whether this is the right endpoint for this patient cohort. If you go for the patient-orientated endpoints, I'm not convinced being this, because you have longer DAPT, you have another hospital stay, you have other complications with the access. So I'm not sure that this is true then.
I'll look forward to TCT then.
Yeah. Thank you very much, David. Yeah. So we go to a very fascinating and complex case by Anuruk Jemanukulkit. You will see, I really appreciate mixing coronary and structural. Yeah.
Thank you very much for very kind introduction, and it's my great honor to present my case in this conference. So I don't have the conflict of interest. I will summarize the key issue of the PCI in elderly, because the key PCI is changed from the other subset, and like the elevation of the procedural risk by the bleeding risk or kidney function, or increase the vascular complication. It's usually a typical presentation, maybe dyspnea, fatigues, and sometimes we will have the problem with the delayed diagnosis of the ACS. The combination of the underlying disease and frailty, like the metabolic and the cognitive decline, may cause the delay recovery or the poor survival outcome. The decision-making is not only the indication by us, but it's shared decision-making with the family. The PCI strategy, so we prefer to do the radial, and the depth should be more short and avoid the complex. That is the strategy. And the outcome, sometimes we have to aim to be the short outcome and prevent the repeat hospitalization. The benefit was reduced by the risk, and the ACS may be the only indication for this revascularization in some doctor. So when compared the PCI in the octogenarian in Thai registry, we have the same. That the successful rate is not different between the young and the octogenarian people, but the complication and in-hospital mortality is higher. With the complex PCI that we have to do, we do the more plaque modification and rotor brader, so we use the transfemoral access more than transradial. So going to the case, is the case of the 83-year-old female admitted with the decompensated heart failure. The symptoms start for 4 months. The frailty score is partially dependent, go to dependent patients. The lab showed that she don't have anemia. The creatinine was rising during she have the symptom of heart failure. The proBNP is very high. The chest film showed that she have the cardiomegaly, and the EKG showed the Q wave and poor progression in the chest lead and Q wave pathological Q in the inferior lead. So this is the echo from the beginning. So you can see that is a global hypokinesia with the severe dominant in the LAD territory. She also have the pericardial effusion, and the valve have the high gradients from the colorful, and is still the tight leaflets. And you can see that it looks like the CVAS. But this case is not achieve the CVAS criteria because she also have the poor year from the stroke volume index. So we face the classical or follow gradient CVAS in this case. And the Korean angiogram, you can see that we also face the very complex PCI. We have the CTO for the RCA, we have borderline lesion for the proximal circumflex, and we also have the CTO from the LAD that have the fan flow from the bridging collateral. The RCAs look like this, so that is very difficult for me to do the revascularization. For the CT, we didn't discuss much about the TAVI protocol, but you can remember that the aortic root is the annular size is just 24. The SOV is larger than 30, and the STJ is high calcification. And all the things is just concerned about the height of the STJ and calcium, because if you do the balloon expandable, we will cause the injury of the STJ. So other thing is quite simple for the TAVI procedure. Another concerning is the advanced atherosclerosis, because she also have the lower limit of the access site in this case, but because the less calcium distribution, we will try the transfemoral. Another thing that is important is the factor that we have to do confirm the diagnosis of CVAS from the CT calcium score. By the female, we have to reach the 1,200, but this case is not reached that things. You can see from the picture that is less calcium at the wall, but other part of the aorta have the calcium, and there was free space for the surgeon to do the cross clamp. So that's why this case is borderline between the PCI and the surgeon. But when we do the heart team conference, the problem for this case is just only the CAD for the octogenarian in the triple vessel disease, double CTO, and the question for the low follow gradient CVAS. But if you calculate for the prognosis of the surgeon in hospital surgery, so it's quite a high population for the STS score is more than 8. And if you do the syntax score for predict the outcome, clinical outcome and anatomical outcome, the syntax score for the anatomy is very high. So for the PCI, maybe you have to send to the surgeon, but surgeon have the high syntax, high STS score. And the prognosis is very bad. 10 years is 99%. We can guarantee that she was not stable. She was not stay with us for 10 years. And the 5 year is also high too. And for the surgeon, they have to do it, but at the end, they conclude in the heart team that they turn down for this case, and the TAVI for the low follow gradient is not worse than surgery for sure. So let's go back to our team again. We have 4 interventions and the fellow for 9. So the fellow is very strict for the criteria. So they not allow me to do the low follow gradient without proving that is severe enough. So we decided to perform the PCI of the CTO RAD because it looked like the highly success, and the complication that for the PCI, I think is can easily prevent and resolve. But the complication for the TAVI, if we choose the TAVI, we have to use the ECMO and the emergency surgery only. And after that, we will prove that it have the CVAS, low follow gradient CVAS by using the dobutamine. Hopefully that we will access not only the AS, but viability of the RAD too. The PCI, for another thing that the PCI can help is prevent the ischemia and prevent arrhythmia during the dobutamine stress test. So the PCI for this case with the stump is not too difficult to find the right stump, and after that I successfully crossed the wine to the distal part of the RAD. With the 2O balloon, 2O balloon, semi-compound balloon, we can get the result like this. You can see that the septal branch is still there, and I think that we are in the true lumen for all of this true CTO lesion. The OCT, because this is a pre-recording, and I present on my teacher, Dr. Onuma, about the OCT learning. So we do the OCT in this case, even though we worried about the kidney function, but just get this picture to guide us to do the PCI. Like the distal reference is about, the lumen is just only 1.74. It's very small, but so that's why we have to use the EL to EL, and it's about 2.9, and downside to 2.25, but more safe, I choose the 2.5 for other balloon pre-dilatation. For the proximal reference, it's 3.0, and you can see from the picture, from the bookmark, you can see that it has a chunk of calcium, and it has no crack. That means it will be limitation for the stent expansion. So we do more with the scoring balloon for this case, and you can see that the angiogram is worse because it has a dissection flap, and the lumen inside the CTO looks smaller than the previous one. So we check the CTO, we check the OCT again, and I saw the many plaque rupture and nearly the calcified lesion. So I think the limitation of the stent expansion is less now. So after you see a lot of database, and for the clinical result of the octogenarian of the Supraflex, it's mandatory to use the Supraflex in this case. And you can see that the Supraflex is very gently going down, even though it's a very long lesion. It's a 40 millimeter stent, and we inflated at 12 atmosphere at the mid to proximal part of the RAD. So we do the post-dilatation as we already think about the proximal part is 3.0. So this is the post-dilatation. For the angiogram, I think it's a good result. No septal loss, and the diagonal is still there. But it has some malposition at the proximal part, about 5 millimeters. So we used a 3.5 to correct it, but it didn't do the OCT to confirm because we can avoid the contrast indifferent property. This dual reference method, you can see that the distal part is 120% expansion, and the proximal part, even though it's 61%, is not reached the criteria, but we can get the area more than 5. So the protocol, like we already mentioned, and this case is just passed for 3 weeks. So we do the PCI, the creatinine is better, the troponin T is not rising much, and we do the dobutamine after 1 week of this case. For the dobutamine result, you have to decide it by yourself about the picture. This is the admission. This is after we treat the medical with the diuretics and some medication. It seems better, but when you get the dobutamine at the low dose, the contractility is get better. The septal, even though it's thin, I think it's more moving. So the S-stroke volume index is achieved 35, but the mean pressure gradient is not reached 40. So that's why I have to convince my fellow a lot. So I want to do this case because I think it's a CVAS, so they agree. So they allow me to do. And something that make me feel comfortable is the invasive, because during the anesthesiologist do the conscious sedation, the blood pressure was dropped, and she gave a lot of inotropic drugs like the noradrenaline, adrenaline, and the dobutamine. So it's generate the gradient above 41. So that's why I feel better to do TAVI in this case. And we do the TAVI with the balloon expandable, and this is the direct shot. And we can get the good result from the angiogram with the trivial AR, but in the echo it's my no choroid complication, even though it's a main problem in this case. But you can see 3 days after TAVI and PCI in this case, the echo is still the same. So we still have to manage many the octogenarian, not only our procedure. We have to do the medication, and we have to calculate the risk, try to short the duration of the APT by using the stent that have the evidence base. And this is all the risks that this case face: the greater bleeding risk, and it's also combination with the CVAS. Thank you very much for your attention.
Absolutely gorgeous case. I mean, combining structural and coronary artery very well illustrated, and I think good thinking about treating the case. I think we are a little bit behind, but I think Elge and Asset and Ashok with the deserved question. Yeah.
Very short question, a really interesting case. Thank you very much for this presentation. Actually, there were 2 CTOs, LAD and RCA, so not a lot of really good coronary arteries left. Why did you decide for LAD, and do you bring back the patient for the RCA after the successful procedures already performed?
Yes, like I mentioned, that LAD seems that I can restore the vessel more easily. And the RCA is quite difficult. And I think the clinical of this case will combination between the both AS and also the CORI. So I think the fixing the LAD is lack of evidence of the survival, but we try to do the low dose of vitamin to prove it, but it's still ambiguous. You can see the picture. And the RCA, I think, is too difficult for me. Maybe I could bring the great operator to help me do the RCA after we collect the clinical of the patients get better. And the next time we will do it.
Yeah, I think it's a very thoughtful case. You thought through it systematically. You did everything. And I think the only thing I may have done differently was the fact that the apex and distal septum was thinned out. There was loss of R waves. Ejection fraction was low. I felt it could have been infarcted. I may have done a nuclear scan or even a PET to try and define whether the LAD was totally infarcted and whether we should just treat the aortic stenosis and expect the left ventricular function to get better.
Yes, that is a great question. So I think the time to treat this patient have to be short, because I want to, it's lack of the evidence, but I try to the old-fashioned to prove the viability by the dobutamine. And if we have to manage with the MRI or the PET scan or other things, it will take time, and the patient is not stable to do that. So I think it's one of the lack information for this case.
What happened to the anti-proBNP after you did the TAVI? Because it
It's the
decreased
same.
only by the same. Okay. So it's going
Not
to be heart
improved.
failure
So we
still.
think that the medication still the major role in this case too.
Yeah.
Okay.
Thank you.
Thank you for the great presentation discussion. So now we move on to the next session, the next talk. The Professor Sirais will talk about the device success of the ongoing multi-vessel talent trial, which is, I think, one of the key highlights of this session, and he incorporates the EuroPCR endorsed device success criteria, but also enhanced method. So, Professor Sirais, the floor is yours.
Thank you, Yoshi. This is my conflict of interest. I think in randomized novel DES platforms, device success is a critical performance matrix. However, previous RCTs have used varying definition of device success, resulting in device success rate ranging from 91 to 100%, which makes cross comparison challenging. And the most common variation in the definition is of final instant residual stenosis threshold, which range from less than 20 to 50. So a couple of years ago, we did with the EuroPCR and the European Society of Cardiology, we give rules to define the device success more stringently. So basically, the first step is, was there an attempt to cross the lesion with the assigned device? The second step is, was any device delivered and implanted in any location? The third was a device implanted in the intended location. The fourth step was the first assigned device implanted. And finally was the final residual stenosis less than 20% by QCA in the preferred methodology. This is the position statement from the EuroPCR and ESC to 98.9%. Now comes the serious business. In 343 lesions, the diameter stenosis equal or more than 20% by the core lab was observed. That's a rate of 8.9%. So you have an instant residual diameter stenosis less than 20% achieved in 19.8%. On top of that, in 160 lesions, there was a delta QFR across the lesion more than 0.05. That's 4.2% rate. So a delta QFR stent below 0.05 was achieved in 95.5%. So we come to a different pictures of what we consider usually as a device success. This is the device success reported by the site. Instant diameter stenosis, visual less than 20%. This is the device success, 95.5%, when you based on the delta QFR across the stent, 0.05. 90.2 is the core lab assessed device success with an instant residual diameter stenosis less than 20% by QCA. And finally, if you combine the delta QFR more than 0.5%, and the instant diameter stenosis more than 20%, then the device success is 86.6%. That's in contrast, it's paradoxical that, and you will see that in the talk of Professor Onuma, that the predicted freedom of 2 years voce in the multi-vessel talent is 95.5. So the long-term outcome is now higher than the device success. So we have to do something about it. We have to do something about it. And this is, as you could see, a peep view. Forget the slide very quickly, but that's a comparison between Synergy and Supraflex. Don't tell the people of TCT that I've shown that slide, but I think it's what you want to see. You come here to hear, and indeed the synergy of the Supraflex is as good as the Synergy. But you could see it's a sobering 86.3% and 86.9% of success with this approach. So since 1977, device success have risen from approximately 80%. You know, when I started in 1980, it was 80%. 20% of our patients were going to the surgery at the end of the procedure. Concurrently, the long-term clinical success rate have declined from 30% to 5 to 8%. That's today the Voce, Doce, and others. Nowadays, acute anatomic and hemodynamic result encompassing both anatomic success and hemodynamic performance serve as a key predictors of long-term clinical success. We have clearly demonstrated that in the syntax 2. Therefore, greater emphasis should be placed on the meticulous assessment and standardized documentation of anatomic success and hemodynamic performance criteria. I think that some assessment post-PCI is a must today. Thank you very much.
Thank you, Professor Siraj, for this very insightful talk about the early result of the multivessel talent. I think we are behind the schedule, but we can have one question, maybe from Anna.
Yes, I have a lot of questions, but we don't have time, so the million-dollar question, okay?
We'll do in private.
Do device success metrics based on in QCI and QFR correlate strongly enough with long-term outcomes like BOSE to justify routine clinical use or only to trials?
You know, it's a very good question. I think that to use the FFR before the procedure is a kind of green light. It is justified to do this lesion from a physiological point of view. But we don't use IFR or FFR post-stenting. You know, we are tired at that moment. We don't want to put again a wire to something which has been stent. So basically, the angiography with the QFR remained the way, maybe a surrogate, but remained the way to judge you have done a good job. Yeah. And we know in the syntax 2, we have both. We had the IFR, the FFR, and the QFR in the post-hoc analysis. And we showed that if you have above 0.9 after the procedure for the QFR, then the outcome is good in terms of voce.
Okay. Perfect. Thank
Good.
you.
Thank you.
Thank you.
Thank you for the great talk, Professor Siraj. So the last talk is by myself, so I will introduce myself. I will talk about some prediction of this.
We could introduce you, okay?
So after this self-introduction, we have Professor Onuma with a good topic, trying to predict what will be the result of the trial. And I say, see Upendra Kaul in the first row with the Tuxedo 2, you will have to do the same exercise.
Yes. So my talk is about the prediction of the clinical events in this ongoing multivessel talent trial. Why the prediction of a clinical event is important, especially for this three-vessel coronary artery disease patient. Accurate prognostication in patients with three-vessel disease is crucial for guiding treatment decisions and also the setting realistic expectation for a physician, but also for the patient. Informing a patient about their prognosis supports shared decision-making, helping them understand the risk and benefit of the options such as bypass grafting CABG or the PCI. The aim of this analysis is to predict prospectively the clinical outcomes of the patient in the randomized multivessel talent trial with de novo three-vessel disease using the validated prognostic model, and we subsequently aim to validate and recalibrate both short-term and long-term prognostic models for future application once the actual results are available. So as you mentioned, as mentioned by Professor Siraj, the enrollment is finished, but the clinical outcome is not yet available in this study. So we aim to predict the clinical events at various time points, 2 years, 4 years, 5 years, 10 years, in a cohort of 1,548 patients. We applied previously validated prediction models such as the logistic syntax score or syntax score 2 and syntax score 2020 to calculate individual level predicted probabilities of mortality and MACE. Within the multivessel talent trial, the component of the syntax score 2, syntax score 2020 are available in almost all cases. And the bootstrap resampling technique was used to simulate the trial 10,000 times and estimate prediction intervals for the predicted mortality and MACE outcomes. In each bootstrap iteration, we resampled the 1,548 patients with replacement and recalculated the predicted mortality for each individual using these validated models. So this is design of the multivessel torrent. I'm not going to detail, but it is basically the combination of the good PCI, contemporary PCI practice, combining the QFR, intravascular imaging, CTO, and optimal medical therapy. And all patients had the 3-vessel disease anatomically and screened by the syntax score 1 and syntax score 2. So the enrollment was from 8 countries and 54 sites. And initially, during the trial, the enrollment was slow because of the COVID pandemic. However, we completed the enrollment of the 1,548 patients last year on September, and 1-year outcome will be available later this year. So baseline characteristic, average age of the patient was 69-year-old. 35.6% of patients had the medically treated diabetes mellitus, including 10% of the patients with the insulin-dependent diabetes mellitus. Anatomical syntax score was 19.7, and ejection fraction on this patient was on average good as 55%. So these are the prediction models used for this analysis. Anatomical syntax score summarizing all the coronary artery disease in this patient, and the logistic syntax score combine this anatomical syntax score and clinical factors such as age, creatinine clearance, ejection fraction, COPD, smoking, peripheral artery disease, stroke, diabetes, BMI, hemoglobin, and white blood cell count at the baseline. Syntax score 2 used a little bit similar but simplified clinical factors, including age, creatinine clearance, ejection fraction, gender, COPD, and peripheral artery disease. Syntax score 2020 is an extension of the syntax score to predict the 10 years mortality or 5 years mortality using the similar clinical factors except for the gender replaced by the diabetes and smoking. This is a distribution of the anatomical syntax score in the multivessel torrent trial as assessed in the core lab. So 67% of the patient has a low anatomical syntax score of equal or less than 22. Approximately a quarter of the patient had the intermediate syntax score between 22 to 23, and 6.9% of the patient had a high anatomical syntax score. Just to remind you, the screening and the decision of go for the PCI was made before the patient was enrolled in this trial, and her team discussed already before getting into the trial the indication of the PCI, sometimes based on the syntax score 2 and also other clinical or anatomical factors. 2 years mortality predicted in this trial was 4.1 using the logistic syntax score with the 95% prediction interval of 3.8 to 4.5%. For the 4 years mortality, the prediction is at 10.8% with the interval of the 10.3 to 11.3%. 5 years mortality, according to the syntax score 2 2020, was predicted as 16% with the interval of 15.4 to 16.6%. 5-year MACE is 22.7%. 95% prediction interval was 22 to 23.3%. This is the 10 years mortality of this population of the patient, 31.8% with the interval of 30.8 to 32.8%. If you look at the vessel-oriented composite endpoint using the post-procedural QFR values, the predicted VOCE was the 6.1% with the interval of 5.3 to 6.8%. And in the sample size power calculation, we used 6.5% for the endpoint of the vessel-oriented composite endpoint, so we are not so far from the predicted and assumed event rate of the VOCE at 2 years. In the future, we will use clinical pre-procedural, which is including biomarkers, imaging biomarkers, and geographic and physiological data, and procedural data to develop a prediction model based on machine learning as done in the syntax trial. So this is a summary of the prediction of the clinical event in the multivessel torrent trial. 1 year mortality 3.2%, 2 year 4.1%, 4 year mortality 10.8%, 5 years mortality will be 16.0%, and 10 years mortality will be 31.8%. In addition, the VOCE at 2 years is predicted to be the 6.1%, and 5-year MACE is predicted to be the 22.7%. So we will see prospectively if this prediction is correct or not correct. And as mentioned, that enrollment just finished last year, so we are in the process of accumulating all these events, and adjudication is ongoing. And accuracy of this prediction will be prospectively validated. And if needed, we can also, we will recalibrate these models according to the available outcomes. Thank you for attention.
I think it's quite fascinating to see that more and more we are able to predict the future, and quite precisely, because we have done that exercise now many times. I had one question for Yoshi, but he has given the response. I mean, we are already doing the machine learning, the AI for the prediction, and it will increase considerably because the hospital is collecting so many things that we don't use in trial that we have to change that. And I think that the Scandinavian countries and other countries are going in that direction. One comment that we do, it's not a question, Yoshi, but one comment I want to do. At entry, the age is 69. So 10 years later, these individuals are 79. That's almost my age, okay? But okay. So the question is, in the syntax 10 years, the real one, who started in 2005, what do you think is the mortality at 10 years? 32%. And we have 31.8%. That scares me because we do all the good things, the QFR, the monotherapy, the IVUS, the OCT, and it's still like that. The second message is the syntax study, the original one in 2005. Basically, one half of the population was using statin, and the other was not using statin. That was still the early day of the statin. You know the mortality of the people who didn't use the statin? 32%. The mortality of the people using statin, 19%. Think about that. The interventional cardiology has to go in secondary prevention. Otherwise, they will be digested by the non-invasive cardiologists using pills, because we have now pills which are so powerful. You know, the LPA disappear from the blood, the PCSK9 disappear of the blood, the interleukin disappear. You have to do something in that direction. And you know, we know the increment of the disease in the stent is there. And we know that this treatment can reduce the neoatherosclerosis on the stent. So we have to do something in that direction. And I would like some reaction of the panel, you know.
Actually, I have a question concerning your talk and your comment,
Sure.
because what I realized is that the patient in multivessel talent are close to 5 years older than the syntax patients. Isn't this the reason for the point you just made? So we have the same mortality, but we have the same mortality in patients who are 5 years older.
A very good remark, very good remark. That's the reason why, you know, the people sometimes when we are talking about syntax 1 and syntax 2 and syntax 2020, they said it looks like Rambo 1, Rambo 2, Rambo 3, you know. I mean, let's be serious, terrorists. I mean, what are you doing? But the question is exactly that. You have to adapt. All the time you have to adapt. These coefficients are not fixed. It will be a big mistake to keep them fixed. So we have to adapt, and it's a continuous mathematical thing. Not difficult to do. Many, many people can do it now, but it's a must. You're right.
Well, but aren't you making a difference, though, in the life that you have with freedom from angina? We are also collecting angina questionnaires, right, in the multi-talent. So although the patients have the same mortality, they probably have better quality of life, which is also the point that David is making.
You know, when you merge both, the quality of life and the survival, that has a name, QALYs, okay? And QALYs is what? Over 10 years, I'm playing golf, I'm happy, and I have no angina. That's the goal. That's the goal of medicine, yeah? Yeah.
Yeah, a short question related with both charts, because it is impressive that the main reason for device unsuccess is the having a stenosis higher than 20%. But this is, for the operators, this is a strange thing, but for core lab, it is a frequent thing. So you told us that we cannot do FFR for patients, but should we do QCA after at least complex procedures, because we think that we are optimistic after PCI, but then objectively we have an stenosis higher than 20% in many cases, and this impact on follow-up.
Yeah, you know, it's interesting is that there are a paper which is coming in the Lancet from Favor 3 China, but it's sub-studies, who say QFR is as good as IVUS. I was very surprised by that manuscript, and the key author is Dr. Ko, which is a good guy in Korea. I think that the beauty of the QFR is that when you are finished, you make an angio. You never finish a case without looking with an angio. So the material is there. The only thing is to have a software which is doing that very quickly. I don't want to wait 5 minutes. I don't want to wait 3 minutes. I don't want to wait 1 minute. If they can do in 30 seconds, I will be okay. Okay? And the second point that we need, and I think the Medis company is working on that, and many others also, is that with all the AI that we have, when we have finished the angio, the machine has to tell me it is an angio of good quality. I will be able to do QFR. I need a small guy on the computer saying, I will be able to do the QFR. And that's when we have that, we will have a high percentage of QFR. And you know, when you see suddenly across the stent 0.07, that's maybe a reason to put a non-compliant balloon bigger and go for it. And if it's not improved and the QFR at the end of the vessel is still poor, maybe there's something distally and something proximally which is not okay. Then it's the moment to use the OCT and the IVUS to say, where is the spot there? And not only you will have the IVUS and the OCT, but you will have the curve of the FFR derived from the IVUS or derived from the OCT. I think it goes in that direction.
Patrick,
if we want to survive, you know.
Patrick, it'd be very, very intriguing and interesting for you to analyze that data of device success in those who had imaging and who did not have imaging, because it's quite likely that the ones who had imaging had lower device success as defined by less than 20% resident stenosis or less than the delta QFR. And I think that's what it's all about, isn't it?
I think we have until
45. So we are
45, so 1 minute. Is there a question of the audience, a burning one? When we said no? One time, two time, three time, adjudicate. Thank you very much.
Thank you.